Hello everyone, welcome back to my YouTube channel. My name is Dr. Hamid and our today's topic of discussion is anticoagulants. Very important topic for the preparation of step 1 and step 2. In this lecture we will cover heparin, warfarin and their mechanisms of action, um, clinical uses, adverse effects. Okay, and the main focus would be on heparin induced thrombocytopenia, which is very important topic for step 1 and step 2. So anticoagulants, they prevent the formation of hypercoagulability. Okay, they prevent the formation of clots. Okay, so in a simple words, and anticoagulants includes heparin, warfarin and direct oral anticoagulants. Okay, so our main focus would be on heparin and warfarin. So let's talk about heparin first. Heparin, first, very important thing is the mechanism of action of heparin. Heparin activates antithrombin 3. So heparin is a molecule that comes and binds to the antithrombin 3. When heparin binds to antithrombin 3 gets activated. When antithrombin 3 gets activated, it decreases the action of factor 2A and factor 10A. Okay, excuse me. This is the mechanism of action of heparin. There are two types of heparin. The first is low molecular weight heparin, and the second is unfractionated heparin. Now, the question arises, what is the difference between low molecular weight heparin and the unfractionated heparin? The major difference is unfractionated heparin has more molecules than low molecular weight heparin. Okay, unfractionated heparin is more effective in inactivating thrombin activity than low molecular weight heparin. Okay, and unfractionated heparin can be used. We use unfractionated heparin in patients with renal insufficiency because low molecular weight heparin should be used cautiously because that low molecular weight heparin undergoes renal clearance. So there are three main differences. First is the unfractionated heparin is more effective. Second is unfractionated heparin has more molecules than low molecular weight heparin. And third is unfractionated heparin is used in the patients with renal insufficiency. Okay, now low molecular weight heparin, the examples are enoxaparin and deltaparin. These are the examples of low molecular weight heparin. They bind to antithrombin 3 via pentasaccharide sequence, and then activated antithrombin 3 binds to factor 10A. Okay, they are directly inactivating factor 10A, which in turn inhibits the conversion of prothrombin to thrombin, which is factor 2. Okay, so low molecular weight heparin mostly is working on factor 10A, not on factor 2A. Indirectly, factor 2 is inhibited, but directly they are inhibiting factor 10A, which in turn is inhibiting the conversion of prothrombin to thrombin, that leads to less thrombin production and anticoagulation. Okay, in contrast, unfractionated heparin binds to antithrombin 3, and which in turn inhibits both factor 10A and factor 2A directly. Okay, so that's why unfractionated heparin is more effective in inactivating thrombin than low molecular weight heparin. Okay, now let's talk about the clinical uses of heparin. So it provides an immediate anticoagulation. We will discuss about the differences between heparin and warfarin, and that would make things more clear. But for now, let's read this. It provides immediate anticoagulation for pulmonary embolism, acute coronary syndrome, MI, DVT. Okay, so these are the clinical uses of heparin. Heparin can be used in pregnancy because the reason is it does not cross the placenta. We cannot use warfarin in pregnancy because warfarin crosses the placenta, and warfarin is teratogenic. Heparin is not teratogenic. We can use, if we need anticoagulation in pregnancy, then we use heparin, not warfarin, because warfarin crosses the placenta, is teratogenic. Okay, and heparin does not cross the placenta. We will talk about warfarin, but let's first talk about, we have talked a lot about the heparin, so I want to make things more clear. So let's talk about the differences between the warfarin and heparin. Heparin, The route of injection is IV or subcutaneous. So the route is parenteral for heparin. Okay, so route of administration of heparin is parenteral. It could be IV or subcutaneous. The route of warfarin is oral. Okay, the site of action of heparin is blood, while the site of action of warfarin is liver. We will talk about it because warfarin, how the warfarin um, is acting on liver. Okay, we will talk about it. Onset of action of heparin is rapid. Okay, immediate anticoagulation. Okay, while warfarin has a slow onset of action. Okay, the duration of action of heparin is hours. Okay, so onset is rapid and the duration is in hours of heparin, while warfarin has a slow onset of action and the duration is for days. So the warfarin has a longer duration of action. It will start producing effects very slowly, but it would work for a longer period of time. Okay, so the duration is for days. Heparin activity is monitored through PTT, partial thromboplastin time, while warfarin activity is monitored through PT, prothrombin time, and INR. Okay, if I'm here, I want to give an example. If a patient, for example, the patient has a history of pulmonary embolism or DVT, okay, and the patient is using warfarin for an example for a longer period of time. So now the patient comes to you and um, has a history of pulmonary embolism or DVT. So we would definitely, the patient is coming here for a follow up to us, and if the patient comes to you, then what test would we offer to the patient? If a patient is on warfarin or the patient is on heparin, we will monitor PTT, PT, and INR. Okay, so these are the tests we monitor when the patient is on heparin and warfarin. Okay, um, because a lot of times what happens is when the patient is on heparin or warfarin, the PT, PTT will be raised. Okay, and I've already talked about that heparin can be used in pregnancy, while warfarin cannot be used in pregnancy because warfarin crosses the placenta and is teratogenic. Okay, if we are using heparin, if we're using a large amount of heparin, a very high dose of heparin, or heparin is using for a longer period of time, or the level of heparin in the blood is very high, that could cause bleeding, so we will reverse heparin. Heparin toxicity can be reversed, as well as warfarin toxicity can be reversed. So for heparin toxicity, we give patient protamine sulfate. Okay, to reverse the activity of heparin, we give patient protamine sulfate, very high yield. Okay, because I have seen questions related to this. Um, Particularly, they were asking about the reversal agents of anticoagulants. So for heparin, the reversal agent is protamine sulfate. We don't give patient fresh frozen plasma in heparin toxicity because the fresh frozen plasma has antithrombin 3. Okay, when we give patient, if a patient has heparin toxicity and we give patient fresh frozen plasma, that fresh frozen plasma contains antithrombin 3, and then that antithrombin 3 will bind to heparin, will increase the activity of heparin, and will further inhibit factor 2 and factor 10, and further leads to anticoagulation, increase the risk of bleeding. So fresh frozen plasma is ineffective in heparin toxicity. Okay, and when there is a warfarin toxicity, we give patient prothrombin complex concentrate or fresh frozen plasma, um, which has an immediate action, and we also give patient vitamin K, but that vitamin K has a slow onset of action. Okay, um, now let's talk about heparin induced thrombocytopenia, then we will talk about warfarin. Okay, so what is heparin induced thrombocytopenia? Heparin induced thrombocytopenia is more commonly observed due to unfractionated heparin. Okay, we have talked about the difference between the low molecular weight and unfractionated heparin. Here I'm again repeating that unfractionated heparin has more molecules than low molecular weight heparin. Unfractionated heparin is more effective in inactivating thrombin than low molecular weight heparin. Unfractionated heparin can be used in should be used in renal insufficiency, while low molecular weight heparin should not be used in renal insufficiency. Unfractionated heparin is the one that more likely cause heparin induced thrombocytopenia than low molecular weight heparin. Okay, there are two types of hit. We also call it hit type 1 and type 2. So type 1 hit is mild. Okay, it is mild, it is non immunologic. Okay, it is mild, it is transient, non immunologic. Drop in platelet count would be low, but still it would be higher than 100,000. Okay, usually hit occurs 1 to 4 days after heparin initiation. Okay, and it is not really clinically significant. So I've told you that platelet count would be low, but it would not be very severely low. Okay, it would still be more than 100,000. Okay, so it only requires observation, and no heparin interruption is required in hit type 1. Okay, only we will observe patient because to see if the platelet count is reducing drastically, so we will then manage patient. Or if the patient has a platelet count of more than 100,000, the patient has no symptoms, so we would not do anything for hit type 1. Okay, now the important type is hit type 2. Hit type 2 is what? Is a immunologic reaction. It is an immunologic reaction because due to formation of platelet activating antibodies against heparin platelet factor 4. So um, heparin binds to platelet factor 4, and then the antibodies, platelet activating antibodies, bind to that heparin platelet factor 4 complex, which leads to platelet activation and prothrombotic stake and thrombocytopenia. Okay, let's read it here. The development of IgG antibodies against heparin bound platelet factor 4, that typically it occurs 5 to 10 days after heparin administration. It can happen earlier if the patient has the prior history of heparin administration. Okay, that antibody heparin platelet factor complex binds and activates platelets. Okay, leads to removal by splenic macrophages and thrombosis. Okay, so we will see thrombocytopenia and thrombosis at the same time in hit type 2 because platelets are consumed consumed in thrombosis, in the formation of thrombosis, so the platelet count would be reduced. Okay, and we will see a drop in platelet count of more than 50% from baseline. Okay, now what is the best initial test for the diagnosis of HIT and what is the most accurate test? The best initial test to diagnose HIT is HIT platelet factor 4 antibody. We will look for that antibody. Okay, platelet factor 4 antibody. The most accurate test for the diagnosis of HIT is serotonin release assay, which is gold standard test. Okay. I have seen the question related to this. The most accurate test for hit diagnosis is serotonin release assay. Okay. How we would manage the patients of hit type 1, type 2? We would first of all we would immediately stop heparin. The second is we give patient direct oral anticoagulants. Okay, and or we can give patient fondaparinux. Okay, the treatment is first is immediately discontinue heparin, then start alternative anticoagulant, which are the direct oral anticoagulants, example ergotroban, and fondaparinux, safe to use because it does not interact with the platelet factor 4. Okay, Now let's talk about antithrombin deficiency. Okay, antithrombin deficiency is also, you will see somewhere in the first aid, is also important topic. So because I'm discussing it here because we have already talked about antithrombin 3. So we have talked that heparin bind to antithrombin 3, antithrombin 3 gets activated and inhibit factor 2a and factor 10a. Okay, so antithrombin deficiency could be seen. It can be inherited or it can be acquired. If it is inherited, it is autosomal dominant. If it is acquired, it could be due to renal failure or nephrotic syndrome that leads to in which antithrombin 3 is lost in the urine. Okay, so antithrombin 3 is lost in the urine, and when antithrombin 3 is lost in the urine, there would be decreased inhibition of factor 2a and factor 10a, and patient can present with with the state of hypercoagulability. Okay, can present with venous thromboembolism and pulmonary embolism, and there would be resistance to heparin, because heparin, how the heparin works, heparin binds to antithrombin 3, and then antithrombin 3 in turn inhibits factor 2a and factor 10a. When the bridge, the antithrombin 3 is not here, heparin would not work. Heparin cannot do anticoagulation, so we will see hypercoagulability, we will see venous thromboembolism, we will see pulmonary embolism. Okay, this is about antithrombin deficiency. Now um we have to discuss about warfarin, which is going to be the last topic for today's lecture. How the warfarin works, I have already told you guys that warfarin acts on the liver. So, in the liver, warfarin inhibits vitamin K epoxide reductase. It inhibits enzyme by competing with vitamin K. So, it inhibits vitamin K epoxide reductase. So, in turn, it inhibits vitamin K dependent carboxylation of factor 2, 7, 9, 10, protein C, and protein S. Okay. For warfarin, when we start patient on warfarin, we monitor PT, prothrombin time. That would be high. Warfarin has a long half-life. It acts for days. Okay, it has the onset is slower, but it has a long half-life. Okay, it is used. Clinical uses are chronic anticoagulation like venous thromboembolism, prophylaxis, prevention of stroke, and AFib. Not used in pregnancy, and we will monitor PT and INR. Okay, when the patient is on warfarin, INR should be in the range of 2 to 3. Okay, what are the adverse effects of warfarin? So bleeding, that could be seen in heparin, also in warfarin. Teratogenic effects, we have already talked about. Skin and tissue necrosis, and the fourth is drug-drug interaction. Okay, skin and tissue necrosis and initial risk of hypercoagulation, this is very important. How when we start patient on warfarin, heparin bridge is very important, because warfarin takes time. Okay, warfarin, the onset of action of warfarin is slow. I have already told you guys that the action of warfarin, onset of action of warfarin is slow. So, in the meantime, when we start patient on warfarin, heparin bridge is very important for anticoagulation. Okay, because there are two reasons of when we start patient. Let's talk about it again. That when we start patient on on warfarin, the warfarin has a slow onset of action, and warfarin inhibits factor 2, 7, 9, 10, protein C, and protein S. But protein C and protein S has a short half life as compared to protein factor 2, 7, 9, and 10. So when we start patient on warfarin, protein C and protein S are inhibited immediately, and factor 2, 7, 9, 10 would take time. So when we start patient on warfarin, protein C and protein S are anticoagulant proteins, so they would their level would get decreased in the blood, and in comparison to protein C and S, the level of factor 2, 7, 9, 10 would get high in the blood. And factor 2, 7, 9, and 10 are procoagulant. Okay, so it after starting warfarin, it should lead to anticoagulation, but it is causing hypercoagulation. Okay, so there is an initial risk of hypercoagulation because protein C and protein S, which are anticoagulants, has a short half life as compared to protein factor 2, 7, 9, and 10. Okay, due to these two reasons, the slow onset of action of warfarin and initial risk of hypercoagulation, we do heparin bridging. We give patient heparin for some amount of time. Okay, so let's read it. Initial risk of hypercoagulation. Protein C has a short half life, then factor 2 and 10. Existing protein C depletes before existing factor 2 and 10 deplete, and before warfarin can reduce factors 2 and 7, 10 production. So it lead to hypercoagulation. I've already um, explained this, that how protein C and protein S has a short half life, their level would go down as compared to factor 2, 7, 9, and 10. So it leads to after administration of warfarin, there is an initial risk of hypercoagulation, and that lead to skin and tissue necrosis. So heparin bridging is very important. This image A is showing skin necrosis. Okay. um yeah, so initial heparin therapy reduces the risk of recurrent venous thromboembolism and skin or tissue necrosis. Okay, and I've already talked about, if there is a warfarin toxicity, we will give patient vitamin K, but vitamin K has a slow onset of action. So, for rapid reversal of warfarin toxicity, we give patient FFP or prothrombin complex concentrate. I have seen question related to warfarin, and they were asking which of the reversal agent has the immediate action for warfarin toxicity. So prothrombin complex concentrate has the immediate onset of action for reversal of warfarin toxicity. Okay, this is all about today's lecture. If you guys have any questions, you can ask me in the comment sections. Thank you so much.